The moderator of our next panel, which is titled Tubes, Tonsil, and Adenoid,
I know you're proud of
is
it.
Dr. Redtfeldt.
So we're going to talk about tubes, tonsils, adenoids. I think this was a request from a couple different conferences that we focus in on some of these really central things that we do a lot of. So I'm going to do a quick briefer on acute otitis media. When do we start considering doing tubes? And then Dr. Hurley is going to do a continuation a bit of his sore throat talk and talk about tonsillectomy. We've got one slide on adenoidectomy alone because that's kind of a not as common thing to do adenoids by themselves. And then we'll do a couple cases, and then we'll all answer questions if you have any. In full disclosure, if we're politicians, we would be disclosing nothing. But thank God we're not. So I don't have any conflicts. So acute otitis media is a 3-week problem. It is clinically very quick to happen. So they go from normal kid to very sick kid. The exam is a moderate to severe bulging tympanic membrane. It really should look close to this bad, if not this bad. Abrupt onset, again, the kid's fine, and then the next day they're not. Fever, usually pretty high fever, and we really do want that bulging drum and the fever. If they don't have that, I'd be a little hesitant to give them an antibiotic. So it's a 3-week illness. These are the 3 bacteria. It's strep, Moraxilla, H. flu. And then if you're diagnosing acute otitis media on someone over 5 years old, think again. You should be not getting an acute otitis media over 5. So if you have adult patients you see and you're diagnosing a lot of acute otitis media, take a closer look. They should really have a bad TM. They should have a fever. Ear pain in adults is usually not acute otitis media. We did a talk a couple years back on that. Really should be a kid, a year old up to 5, but not really usually over that. And usually it stops at around 3 years of age. So here's your normal drum on the right, patient's right, and the bad drum on the patient's left. And then as soon as they start having this over and over again, we start calling them otitis prone. And otitis prone is defined as 3 acute otitis media in 6 months, 4 or more in a year. And so as soon as they start getting that many infections, then you should start thinking about sending them to an ENT. Our medical management is going to depend on their age. So Dr. Mami mentioned earlier, should we even be treating acute otitis media? And if they're over 2 years of age, you might not. So you might have the fever and the bad drum, and you can have a discussion with the parents on what they think about antibiotics. There are some people out there worried about microbiomes and effects of antibiotics, and they may agree with you to not do an antibiotic. So that over 2-year-old, you can, even with the actual, real deal, wait a couple days and decide if you still want to do that antibiotic. If they're under 2, if they're not a neonate, so this is not a newborn, but if they're under 2, over 2 weeks of age, it's high dose amoxicillin. So it's pretty much double the dose that you ordinarily give. It's 80 to 90 milligrams per kilogram per day, and so we're dividing that, BID usually, and so it's 45 mg per kg per dose. And then you're going to start with that. If they're over 2 weeks, under 2 years of age, you're going to start with high dose amoxicillin. You're going to see them back in 48 hours, 72 hours, or at least have the option of having them come back if they're fine. The fever's gone, the kid's better. You don't really have to bring them back in, but they should have the option of trying to see you again 48 to 72 hours later. And if they're not better on the high dose amoxicillin, then go to Augmentin. If they're 2 years of age or older, then you can have that discussion if you want to about not doing the antibiotic, or maybe writing the antibiotic and having them hold it and see if they can just get the fever down and get the kid feeling better on ibuprofen, Tylenol. And then again, in 48 to 72 hours, if you did the no antibiotic course and they're not better, then you're going with the high dose amoxicillin. If you did the high dose amoxicillin and they're not better in 48 to 72 hours, now you're going with the Augmentin. When I say they're not better, it's not that their ear looks a lot better. It's that they are better. Their fever is better. Their pain is better. So that eardrum is not going to look a ton different. If you see them back and you're like, the kid's better, but you look in their ear and their ear looks really bad, you don't need to up their antibiotic, okay? So when is a new episode? So if you have an ear infection and then 2 weeks later they're back with another ear infection, then you actually don't start back at the beginning. So if they had an ear infection and then 2 weeks later they're back with another one, you would go straight to the Augmentin. You wouldn't do the high dose amoxicillin because it's within 30 days. So the key is 30 days. If it's within 30 days of their last infection, you're just going with the Augmentin. You're not doing the high dose amoxicillin. Okay. If it's more than 30 days, then you're right back at the beginning, high dose amoxicillin. Okay. And so when are you going to use other things? Well, if they're unresponsive to Augmentin, cephalosporin, and Zithromax. When are we even using the cephalosporin or the Zithromax? That's for our penicillin allergic kid. So if we have that penicillin allergic child, we're starting them on a cephalosporin instead of that high-dose amoxicillin and instead of the Augmentin. If we have a cephalosporin and a penicillin allergic child, then we're doing Zithromax. Okay. If they fail that, then we're going to Rocephin shots. It says, the guideline is Rocephin or clindamycin. I very rarely use clindamycin in children. They really will not take it, and then it's bad on their gut, and sometimes even worse than Augmentin is on the gut. So the Rocephin shots, especially, you guys have that at your disposal. That's where you'd go if they're failing the Augmentin. And then, of course, we talked about the allergic to amoxicillin. There is this possibility, especially if you have those really combative children that will not take anything, and you think you might get one dose in. If you're lucky, you can do Zithromax at a high dose. You can do a 30 milligram per kilogram times 1. You don't want to use that all the time, but if you're desperate, you can do that as a one-time dose for the full treatment. And then for your neonates, if you have a patient in your office that's a newborn and they have an acute otitis media, you are not thinking about the normal bacteria. Now you're thinking about birth canal bacteria. So we're talking about the group B streps, gram-negative enteric bacteria, chlamydia, and that's a full sepsis workup. If you have a neonate, a newborn in your office, and they have a fever and they're sick and they have an acute otitis media, they should be going over to the peds hospital. Yeah. And then if they're over 2 weeks, you can do the same thing, the same protocol, which is the high dose amoxicillin, Augmentin, Rocephin route. So, this recommendation was made by the pediatricians in consortium, and the Peds Infectious Disease people needed to make a comment on it. And so what they said is, they agree with the recommendation and that they kind of ferreted out some more details, because there are some questions in it, which is if high-dose amoxicillin is only a 57% cure rate, why are we starting with that? And if Augmentin is a 99% cure rate, why don't we just start with that? And basically their response was that some of these spontaneously cure. High rates of spontaneous cure. These are isolates, they actually confirmed an AOM that was strep pneumoniae, and it had a 20% spontaneous cure. There are bouts of this that we cure ourselves. And so strep pneumonia, 20%, 50% H flu, 80% Moraxilla. So that's where that, Dr. Mami says, should we be treating it? Well, maybe sometimes we shouldn't be. And so that's why we're starting out with high-dose amoxicillin. We're not going to the Augmentin right away because we've got some spontaneous cure. And then the other thing is we're 50% wrong when we make the diagnosis of acute otitis media. It's a high rate of over-treating disease. And so I think you still can be comfortable with the amoxicillin. If you have a mom that's like, look, that never works, and you're sure that you have the diagnosis, certainly use your clinical judgment and do the Augmentin, okay? But the overlying thing is high-dose amoxicillin should work. And there's full agreement on that protocol that I just went through. And then this is the otitis prone stuff. So more than 3 in 6 months, more than 4 in a year. We used to say 4 to 6 in a year, but you can, you don't have to wait a whole year to assess. You can really do it. As soon as they start getting repeated infections, you can send them over. And then the guidelines are accepted by the Academy of Pediatrics and by the ENT Academy, and they are that you may consider tubes at the over 3. And that's not an automatic thing. You may have sent someone over to an ENT for tubes and they may not have gotten tubes. There's usually a pretty long discussion with parents and how big of a deal this is and what the ear looks like at the time. And so just because you're sending them over for tubes, it's for evaluation for tubes. So don't think that you have that weight on you that you're deciding that this person needs ear tubes. Send them over, we'll evaluate them. And in our academy has said, look, they may have all these infections, but if their ears are great, when you see them, do not put tubes in. This is a moving target, right? We've got this kid, they're a year old, they're 2-year-olds, and now sometimes they're gonna be done with this problem, and we don't want to be putting an ear tube in like right as they're already done, right? So they had 4 infection, they finally got to see you, and the ear looks good. Maybe that's their last run of it. And so they really, when we see them, we do a middle ear pressure test, we do a hearing test, we look at their ear, and we make an assessment of whether or not it needs to be done. If they've got fluid, if they've got retracted drums, they're getting ear tubes, or at least a recommendation for it. If their ears are good, then we're waiting on those people. We're gonna see them back. We might see them at the time of their next infection. We might do TIMS when they're next sick, et cetera, to try to see if that kid still needs tubes. So don't feel like, you sent someone over and they didn't get tubes, that we didn't agree with your assessment. That's not the case. Or vice versa, which is that I don't know if they really need tubes. Send them over, we'll evaluate them. We won't be putting a tube in a healthy ear. We'll be making an assessment also. And then Dr. Hurley's gonna come up and talk about acute tonsils. We'll do 2 case presentations and then we'll take questions.
Okay, is this working? Oh, actually, if I go here, will I be good on your mic?
Okay, good.
So I'm just gonna sit here. Tonsils in 5 minutes. The most important thing to remember is that it doesn't have to be strep to qualify as a tonsillitis. We have a table in your handout that goes over all the various viral and bacterial, but when you're talking about who gets their tonsils out and who doesn't, did you give me the clicker? It doesn't have to be strep to qualify. So this is the recommended antibiotic regimens for your review. I'm not going to go through them in detail. Obviously, strep, non-strep, everybody gets supportive care. These are things you're recommending on a day-to-day basis. Hydration, Tylenol, humidification, avoid overuse of irritants. And then the tonsillectomy criteria. It's 7 for 1, 5 for 2, 3 for 3. And the most important part of this slide is that the clinical features of a tonsillitis are swollen tonsils plus either a fever or pain or lymph nodes, and that counts as an episode. And so if someone comes in and says, well, I've had 6 episodes, but they're always strep negative, what can I do? Sometimes they've been told, you don't have strep, you don't need your tonsil. No, that person will still benefit. Relevance. Tonsils are the 2nd most common ambulatory surgical procedure, 15 million visits a year for sore throats, 300,000 tonsils on the children under 15. We have to remember it is a surgical procedure. It has a risk. There's a 2% risk of bleeding. So while it helps people, not everyone needs it, and it's not for everyone. Parents have to be aware of that as well. It's a little bit more common to see people with obstructive symptoms because there's mid-facial growth issues, and sometimes the dentist will say, let's get their tonsils out. And certainly while that may be helpful, you have to remind the parents, wait, this procedure has a risk and there is rare mortality. Now the problem is the data on mortality is terrible. So 1 in 20,000 is out there. That's from the 70s. Nobody knows. National Health Service in Britain says it's 1 in 2 million. Fortunately, it's very rare, but when we're taking real risks, we should have a real problem. Surgery, it's an outpatient surgery for anyone over 3 years of age, takes about 10 minutes to 30 minutes. All the kids go to sleep breathing a mask. There's no IVs, there's no shots. It takes about 1 or 2 hours in recovery. Post-op days 3 to 7 are the worst. All tonsils look infected after they have been taken out. So if they come in your office and you see that fibrinous exudate, it doesn't mean they're infected. So that also means that since the guidelines now say no antibiotics with the surgery, if they have fevers and they look bad, no point in culturing anything, just throw them on antibiotics because you can't tell the difference. 2 things on the side that are important. Anybody with higher risk, you have to think harder on. And then, a lot of this for obstructive symptoms becomes, does your child have a severe enough problem that they need intervention? Because if the answer is no, then the discussion's over. Doesn't matter how big their tonsils are. Take-home points, most tonsillitis is viral. Tonsils don't have to be strep to meet criteria. 7 for 1, 5 for 2, 3 for 3. Peritonsillar abscess is an acute complication of tonsil infection, which is outside the criteria and needs immediate referral. Adenoids, 2 seconds on those. They're the tonsil of the nasopharynx. Mouth breathing, positioning like the kid on the left. I think these pictures are courtesy of Dr. Redtfeldt. So they'll come out for severe obstruction, recurrent sinusitis with tonsils in kids, or if you're getting a second set of tubes. Back to you.
Oh, should I just sit? So the first case in presentation is a 20-month-old female. This or those?
Both.
Oh, both. Okay. So 20-month-old female. She's otherwise healthy. This is definitely her. It was not from modernmom.com or anything. So she's got fever, and she's been having fever for over 24 hours. Mom's been doing the ibuprofen, acetaminophen, alternating dosing. And then she has left-sided ear pain, and by report, she has left-sided ear pain, and by report, she's got thick mucus from her nose. And prior to all this, she'd had a runny nose for a few days and a low-grade fever, and that all went away, and then this came on. And her backstory is that she's had 3 ear infections since she started in daycare 6 months prior, and that the last infection was bilateral. It was 3 weeks ago, and she did respond to amoxicillin. So we do our exam, and that is our eardrum still. So her right drum just has an effusion, and the left drum looks like that. She is warm to the touch, even on the ibuprofen, acetaminophen, and she's 100 degrees in your office. She does have intranasal congestion. You don't see any colored secretions, but mom's been suctioning her nose. And she's got erythema of her oropharynx. Her upper cervical lymph nodes are palpable. They're shoddy, and she does have a bit of a wet cough. And she's crying. It's hard to kind of hear her chest, but she doesn't sound like she's wheezing. Any thoughts on this child? Anybody want to comment? What's that? Okay, so that's the thing. So she's within 3 weeks of her last infection. Now, she did respond to amoxicillin last time. So that's the thing. Do we start at amox? No, because it was 3 weeks ago. But she responded to amoxicillin, so I would go to Augmentin now. But say 3 weeks ago, she went on amoxicillin, she failed it. She went to Augmentin, she responded, and now we're seeing her? Yeah, you have the choice of going to Rocephin.
What does the daycare got to do with it?
Yeah.
With the bottle?
No, so the daycare thing is one of your highest risk factors for acute otitis media in kids. So, I try not to make a big deal about this. I try to get the information, but most people do not have their children in daycare because it's an option. And so I don't do I just let them know, we all just say, hey, well, clearly, she's getting these exposures at daycare. But it is very difficult, of course, to have that conversation with a mom who's feeling guilty about taking her kid to daycare. The tubes will help it a lot, and then the long term is that they're going to, if they get the tubes, they're going to be fine. They're not going to lose their hearing over this if they get treated. And so for the really worried mom who's like, would I need to quit my job kind of stuff, I just say, look, let's put the tubes and see how they do. And usually they do fine, but it is the risk factor here. If you had uncle moved into the house and is a smoker, that would be your risk factor. And then that, of course, we have to kick the uncle out. So yes, the key points on this were, it is a real acute otitis media. It happened again within the month, so we're not going all the way back to high dose amoxicillin. We're going where we stopped, so it would be Augmentin. And then now the other thing is the recurrence. Yeah.
Augmentin, the dose will be the high dose?
It's the high dose. It's that 90 mg per kg. Yeah, it's high, and so you might see some of the gut stuff because you increase the amox, you increase the clavulinate, and so sometimes people will go to Ceftonir here to avoid the gut. If you've had a kid where the Augmentin is a trouble for them, I'd go to the Ceftonir. So then what about the fact that this is the fourth one? And yeah, so I would send them. And then the person did send them. This is what we caught, which was, it was 4 bouts because it was the 3 and then the 1 that you just treated. And that 2 had been bilateral, 2 had been unilateral. I get that information. I don't know that it's really pertinent. I have known people who count bilaterals as 2 infections. I don't. And then we also gather data on rupture. If every one of the infections is a rupture, we might be more tending to do tubes earlier than later. And then they responded to amoxicillin. They required augmentin 2 times. They did not go to Rocephin shots. And then for this child, there is this associated nasal stuff. But when she's not sick, her nose clears up. That's important because we want to determine if they just need tubes or do they need tubes and an adenoidectomy. If they stay gunky all the time and then they get the ear infections, then we may be doing tubes and adenoid in this age group. She's at daycare 5 days per week. There's no smokers in the home. And then there is a family history that's positive. If we don't have these timpanograms, this flat timp on the right and this slightly negative timp on the left, then we aren't proceeding with tubes. If these eardrums move perfectly normally when we see them, we're not putting tubes in this child, at least not right away.
I just have a quick question about, so if you already went to augmentin and then you decided to do Rocephin, how much are you doing? Are you doing
It is the 3. Yeah, so they don't actually delineate that in the protocol. There are people who do 1 shot of Rocephin and then continue on the high-dose augmentin. But I would tell you, if you have a sick kid, now this is a high fever, not responding to augmentin, I would at least do the Rocephin shot and make that appointment the next day for the second one. But yeah, it's supposed to be the 3, Rocephin 3 days.
Are you doing 25 to 50?
25 to 50. Yeah, the range, yeah.
Now, do they automatically do the tonsillectomy with the adenoidectomy?
No, so that's...
The question was, do they automatically do the tonsillectomy with the adenoidectomy?
Yeah, so you do automatically do an adenoidectomy with a tonsillectomy. So that's where this confusion is that when we do the tonsil, we always look at back in the adenoid, and if there's adenoid tissue, we do remove it, because when your tonsils are inflamed and diseased, your adenoids are too. And then if your tonsils are big and you're taking them out for obstructive sleep apnea, then you need to take the adenoid out too. But the converse is not true anymore. It was a long time ago, but it isn't anymore. And so that's why, we had these questions about adenoid. So adenoid is almost always done either with a set of tubes or with the tonsil, except for those few situations that Dr. Hurley mentioned, which is the kid, for whatever reason, they've got great eustachian tube function, but their nose is always clogged and their adenoids are really big, right? That their adenoids grew 3, 4, 5 years of age where they already grew out of their ear problem, and then the adenoid isn't affecting the ear. You're going to do adenoid alone. Lots of those kids will have really bad asthma when they get sick, and so they're super, super sick when they get sick, and sometimes the adenoid will help for that. But you do not automatically remove a tonsil with the adenoid. The tonsil is a much higher risk procedure. 2% chance of bleeding is real. We do well over hundreds of tonsils in a year, and so you're going to see bleeding. And the adenoid's like 1 in 3,000. I always knock on wood when I say this, which is I haven't had to take an adenoid bleed back to the OR. They're just uncommon.
Adenoids are basically recover. I get
Yeah.
the volume. The adenoids are simple to recover from. They're nothing. I'll tell parents, your kids, you're going to wonder whether I actually did something. And so then if you, to reiterate, with tubes, when you're talking about ears, second set of tubes, always adenoids. Under 18 months, almost never adenoids. And then 2 years and up, it's a question, and I'll present it as an option for the parents.
And do you use the microphone?
Oh, I need to use the microphone? I'll present it as an option for the parents. Specifically, okay, is this your classic snotty-nosed kid, mouth breathing all the time? Let me take the adenoids out. We're not going to meet again in 18 months when those tubes fall out. And some parents aren't as comfortable with that because when you do adenoids, it's a more invasive procedure. It means an IV and an endotracheal tube, whereas tubes are just a mask. And if they opt not to do the adenoids, that's fine. But it's in the thought process. And for my own kid, first set of tubes, 2 and up, and snotty-nosed kid, they're coming out.
I do tell patients on the parents when they're deciding on the adenoid that it will decrease the chances of a third set of tubes by somewhere around 70%. So if you really have that kid who's otitis prone, their tubes last them 6 months or instead of a whole year, and they've got the gunky nose, and then they're being treated for the gunky nose too, right? They get super bad, and so the adenoid is helpful.
Can I have the clicker, please?
Yep.
One more comment on the we never put tubes in with a clear ear. I'd say never's a big word.
Okay.
Those
I
are
accept.
Those are the and those are the criteria. But you know, when I was a resident, I always felt like I had this resource I was somehow protecting from people, and then I had kids, and I was like, oh, that's what you're going through? Well, you know. So one, if it's that bad, you can help them, and two, there's a little bit of social environment, because if the kid is always going to urgent care and they're being diagnosed with otitis, but you don't know that it's otitis, but they're getting 6 antibiotics a year, I'm like, well, once tubes are in, if the ear's not draining, you don't have an infection. And so there is that thought process, because you don't want kids on recurrent antibiotics. So, second case. The acute tonsillitis versus abscess. I set this up trying to say, if you're in the office, what are you going to do with it? 13-year-old who's pictured in the lower right-hand corner with a 7-day history of throat pain, cervical adenopathy, fevers up to 102, and her ear hurts. And that's actually my 13-year-old daughter pretending to have ear pain. So I'm expecting a call from the Hollywood anytime. She was seen in urgent care at 3 days, strep negative, went home. 5 days, started to have increased pain with swallowing, and was started on Augmentin empirically. And now she's either in your office or could be in the ER with dehydration, dysphagia, globus sensation, and ear pain. And the picture, the exam looks like this. So not a lot of exudate, not very exciting, but there's some subtle fullness on the right. And so, you know, the next issue is, what do you do with this? What if let's say they're in your office, and now we're going to, maybe you send them to the ER if they look terrible. Now, backing up, if they're in your office and you said, airway's okay, it's been 7 days, can I treat them? Yes, you could treat them. You could change their antibiotic, put them on a steroid, and after our talk today, you're going to find out that ENTs love steroids. But but you'd have to get close clinical follow-up. But in this case, we send them to the emergency room, and they get a CT. And the CT has a big red arrow on it, which is very helpful. So there's a little, if it transmitted, there's a little bit of hypodensity, but not much. And so this probably got read as abscess versus phlegmon in the report. So now they're in the ER, and the question is, what do we do with them? You have a couple of options, and so much of this depends on the history. So if the history was 3 days and no antibiotics, you'd say, oh, no problem, steroids, home and antibiotics, follow up with yourself or us in a couple of days. There's a pretty good chance it's going to go on its own. 7 days in, been on antibiotics, failed, the chances that's going to work is very rare. So the next step in that treatment algorithm is, do we or do we not drain them, and do we or do we not admit them? Clinical decision again, 13-year-old's going to get admitted, IV antibiotics, they might get better, and I'll tell them you're probably going to end up getting drained in a few days anyway, but if they get better, you can send them home on oral antibiotics and wait for them to develop. I compare this to a big zit on your face, where you get that red, bump that's terrible, but you can't pop it yet, and maybe it'll go away with whatever they're putting on them topically now, or maybe it's going to be a whitehead in 3 days. It's just going to take time. Admission for IV antibiotics is an option. The other option is you could drain them. It's easy to drain in the ER. You inject them, you numb them up, you stick a needle in there, and usually a needle alone is enough. You can put a knife in there if you want. The question is, will a 13-year-old let you do it? Some of them will, some of them won't. If they'll let you do it, you're probably going to stick a needle in there at 7 days. At 3 days, you wouldn't, because they'll feel so much better. If they won't let you do it, you're going to admit them overnight, see how they do before you end up putting them in the operating room for a tonsillectomy, which is what happens with children if you can't just aspirate them. So that brings us to the third option, tonsillectomy. If you have a peritonsillar abscess and they go to the OR, which is probably what's going to happen based on the 7-day history, you're going to take out their tonsils as well. So when you see those kids you send over had a peritonsillar abscess, you're like, what happened? Kids are going to college, you need to pay the bill. Why'd you take out the tonsils too? Nope. It's if you have an abscess and you're in the OR, at least in my hands, you're going to take them out so you're not there again. Whereas an adult, if they have a peritonsillar abscess and you drain them in the office or you drain them in the ER, they don't need their tonsils out. Wait and see what happens. So questions, comments?
The question is recurrent ear infection with some drainage, but it's not clear is it an adult or a peds patient.
Either case.
So for peds patients, especially in that group that's in that AOM time frame, they don't generally just keep fluid. When they have fluid, nobody even knows it, and then they get the infection, and then we see it, usually for the 2-week to 5-year-old or 3-year-old. For an adult, you'll see this all the time, where the patient has some fluid. They're not in a lot of pain. They just have some congestion in the ear, and then it may or may not correlate to allergy. So it's a totally different person, and it's a different clinical entity than an acute otitis media. And so if you look in that ear and it's not big, red, bulgy, and the patient doesn't have a fever, then you're really looking at probably more of a chronic thing. And absolutely, it's going to be allergy treatment, and I'd say the most effective thing would be to do Flonase, and I generally have them do that at night and have them lay back and even lay on that bad ear and really collect that med by the eustachian tube opening. But they're totally different things, and the adult usually is not infected. They'll have pain sometimes, but sometimes they won't have pain. If you have a patient with severe pain in their ear and they're an adult, you should be highly convinced that that's really an acute otitis media by exam. Because usually it's not. It can be jaw pain, it's excruciating into the ear, some neck pain, some migraines, and again, I gave a talk a couple years back on that, but it's usually not acute otitis media.
Got a question here.
I have a question. Do any of you, I know you practice in Mesa, but so my office is at 50% of your practice. Does anyone have privileges at Banner Thunderbird?
Yeah, who's our people over there?
Hospital?
The privileges I can't speak to, but Jerry Altman, Ish Hakim, Marty Libling are over in that area.
Because we sent the patient for unilateral tonsillar access to Banner Thunderbird. They said they don't have ENT on call.
Well,
Then she got transported to downtown, and then the ENT actually never saw her before they discharged.
so that one, in someone who's not acutely ill, it is much more efficient to send them to the ENT office and ask to talk to the physician if you need to, or if you have tire text or whatever, because one, they'll get treated cheaper, more efficiently, and faster. And then just a brief word on ENT. Most hospitals don't have ENT coverage all the time. So anytime you're sending someone for ENT evaluation, if they're not acutely ill, try to get them to our office. Or discuss with the physician, ask where you want them to go, or make sure the patient calls the ER and says, do you have an ENT on call? Because that saves the whole transfer process, and that's just something that's a problem in the valley.
Yeah, so what we would do is if someone calls us with a peritonsillar abscess and the person is really sick, I will have them send them to Banner Desert, which is my closest ER, and then tell them to call me specifically, and then I'll go see that. So I get the name, so you can do it that way, or have someone try to work them into their office. But some of those people are really sick, and they do need some IV antibiotics at a minimum, even if it's just cellulitis. Do you do the same for peritonsillar?
Yeah, I mean, usually my local referring physicians will call me directly. You're really not, you can't get off the hook when you've talked to them face to face. And yeah, I would usually have them, if they're not toxic, come to my office if they're old enough. I like to train them in my office. I have the best tools and instruments in my office. When we go to the ER, it is such a experience to try to get the things that you want. And the nurses are busy with some trauma or something else, and they really don't want to help you. So the nice thing about the ER is they do have intravenous morphine and medications for nausea, and so that can be very beneficial. And certainly if you have a patient who's getting dehydrated, it's the overnight admission with IV fluids. It makes a big difference with steroids for 24 hours as well. Again, we like steroids.
Got a question here.
Yeah, I'd like to know what is the criteria for tonsillectomy in adults. I have a lot of adults that it was supposed to get as a child, but the parents were afraid, so they didn't get it done, or they were never evaluated. But it seems to me every time I send them, they say, oh, the risks are too much for the adults, we prefer not to do it, but they come back to the office with recurrent sore throat and tonsils, inflammation, and so on.
So it's always interesting because there's a lot of urban legend, I think, unless I'm not reading the right books, that it's so much worse for adults. Well, the pain is worse, but the bleeding risk is like 0.1 percentage points higher. It's not really riskier. So the criteria for the adults is the same as children regarding infections. Again, the adults usually aren't going to have strep, but if they're getting that frequently, and I'll talk briefly about tonsil stones. Because the adults with tonsil stones, sometimes they'll see people and they'll tell them not to do it. But if you have had a family member who's had tonsil stones most of their life, they can be a big social thing. They can cause halitosis, and they're very grateful when you offer them that option. Certainly you don't need it. So anyone with tonsil stones who says, look, they're all the time, it's a big deal, I'm sticking Q-tips back there, I'm like, well, you ready to trade a week to 10 days, the worst sore throat of your life, to get rid of it forever? Because if you are, I have a deal for you. Yeah, I mean, so, and then obviously any suspicious mass or asymmetry is a potential indication. I don't know if you. No.
Yeah.
Yes, insurance will pay for that. I've never been denied or even been, it's a chronic tonsillitis.
It's one of the less expensive surgeries. And I lost where I was going.
Obstructive sleeve, tonsils.
Yeah, so obstructive sleep. What I was going to say is I have this conversation with the patient who's at that age. I tell them the risks. I certainly think you take these guidelines as a guideline. If you have a child who's been hospitalized twice for tonsillitis, that's twice in a year. I'd consider taking their tonsils out, but they were hospitalized. Then I have a kid who says they have symptoms every single month, but never got antibiotics, isn't that sick. I would push that it's more elective. I still probably would offer, but I push that it's more elective. So there is a range of these symptoms and presentations. You got to take them into consideration.
I do think there are some ENTs that do not like to do adult tonsillectomy. And if you have one of those as who you refer to, you have to find another one specifically for that patient. I do adult tonsillectomy. I think we all do adult tonsillectomy. They have to know that it's going to be the worst experience of their life. Otherwise, they will call your office and they will literally be like, I'm going to die. I'm dying, and they don't want those calls. So you really do have to, those patients have to know you will pay for the fact that you're going to be free of this problem forever. That's the patient that comes back and goes, well, you weren't kidding. It was terrible, but thank you. I feel so much better.
And one last comment, we talked about risk, but I think one risk to discuss with them is loss of taste. So most of them don't, but there's quite a few that will have a temporary loss of taste, and preparing them for that saves a lot of phone calls from you guys as well.
It's temporary.
Yeah, it's temporary, although I've had 1 or 2 patients that it lasted like 2 to 8 weeks. And when you got to tell them it's just sugar, salt, and sweet. It's not smelling flowers and chocolate, but that's very annoying. And so I think it's all about preparation. You tell them the experience, it's a gut check. Mm-hmm. If they hear when you're going to talk a little funny, you could get dehydrated, you might have some loss of taste, and there's this risk of bleeding, and you do all that. You're going to get the patient who really thinks they have a bad enough problem.
Mm-hmm. But loss of taste, I had one 6 months. If they're, it's almost always a female, and I think it lasts longer if they're older, and it's usually like really weird. Like they can't have their coffee, the ice cream tastes weird. Like no sugar in taste is significant.
2 other just points that you might get called on. You don't have an ear infection if you just had your tonsils out, unless you're the one person in 20 years. The ear pain is from the tonsils. Second, when you're talking about kids and you're talking to the parents and their kids in pain, and they won't take their meds, they just go to the ER. Basically those kids are dehydrated. And so I always talk to the parents and hopefully we're getting this call, but you guys might get it. And you can refer them to us. But it becomes a situation where if they won't take their meds and they won't drink, I'd say, you've kind of crossed that line. If you're done, go get tanked up with IV fluids, either urgent care, make sure they do IVs because they don't all, get them some Zofran, and the world will be better. Just don't fight the battle. So.
We're going to do 2 more questions, and we're going to take our break.
It's with the hypertrophy of the tonsils. So even adults or young adults, they have like 3+ tonsils and they snore, daytime somnolence, so obstructive sleep apnea. Do they have to have like, do you just say all those symptoms and then refer to you? Or do they have to have proof of obstructive sleep apnea before we refer to you?
You don't need proof.
Kids too?
So on the obstructive end, if it's a parent that's reporting apnea, that's good enough. If on the adult, if they report gasping, waking up, on the adult end, I may get a sleep study if they look like they are severe obstructive sleep apnea and that I'm going to remove those tonsils and they're not going to be cured, right? So on the adult, it's a little bit of a judgment call, but on the kid, you absolutely don't need a sleep study. On the kids, I will get sleep studies under 3 years of age, and mainly just for my own comfort level that I'm not putting an under 3-year-old, which I consider a slightly higher risk tonsillectomy, through a procedure that maybe they just need their adenoids. In the little kid, it can be hard to tell if they really. So in the under 3, I do sleep studies, unless they're really, really almost 4. Like there's some variation in there. Do you comment on this?
Well,
So do you do in home sleep studies or in lab?
The adults are almost all at home.
Little kids.
Do you
The
do
kids are
in-home
always in
or
the.
in-lab?
There's no home.
There is no home sleep study for the
For
kids,
kids.
so we do it in the lab. And for that reason, I tend not to get the sleep studies. I get a sleep study when I'm trying to avoid surgery and I want the parents to feel comfortable. I will make the judgment call whether I think it's tonsils or adenoids. It might be beneficial to start with the adenoids. But that's a style point. I think in general, when we're keeping them over, when we have a really big suspicion for a patient that they don't breathe well, we might, and they're under 3 especially, but we might keep them overnight after the surgery and just watch and make sure that reassures the parents that when they go home, they're going to be breathing okay.
Yeah, for me, I have a discussion with the parents. And for me, with kids, shared decision making is so important because some kids are going to have complications. The parents have to be bought in. So my statement is the American Academy of Sleep Medicine says everyone should have a sleep study, including children. But I'm not the American Academy of Sleep Medicine. And so if you know that you want your kids' tonsils out because they're stopping breathing and they're sleeping at night, I'm not going to make my decision based on the sleep study. If it's negative and you say they have apnea, I'm going to believe you. If it's positive and you say they're not that bad, I'm not going to take their tonsils out because of one bad night. I do, however, encourage parents, so if you're seeing and referring him, like, give me a video of that kid sleeping because I want to see his position. He's going to have his head cranked back, his mouth open, and that's very helpful for documentation.
Okay, so we're going to go ahead and take our break.
Thank
Thank
you.
you very much for a good first session. Across the hall, there are refreshments.